phospholipids, and then there is the alteration change in formation of.
Okay, good. So yesterday we finished systemic coagulant. Okay, in systemic coagulants we have different agents like vitamin K, desmopressin, ethamsilate, antihemophilic factor, fibrinogen. So these are the different parenterally or orally given, that is systemically used coagulant agents. Okay, so today we'll be starting from the local hemostatic agents, that is also known as styptics. Okay, why these are called local? Because they can be applied at the site of bleeding. So these drugs should not be taken by oral route or should not be used by other parenteral route. So whenever there is a bleeding from the small capillaries, whenever there is oozing, okay, small blood vessels ruptures, so you can apply these agents directly over bleeding point. Okay, no need to give by the systemic route. So they are classified under local hemostatic agents. Clear? So this styptics are the local hemostatic. We have the different compounds, okay, different drugs like astringent, adrenaline, thrombin, fibrin glue, gelatin, calcium alginate, oxidized cellulose, tranexamic acid, and hemocoagulase. Okay, so these are the different local hemostatic agents where we can use at the site of bleeding. Okay, small oozing or small capillary bleeding, wherever there is an accessible site. Let's discuss one by one in brief. Okay, astringent. Various astringent can be used as a coagulant agents like tannic acid. This is the most commonly used astringent, that is 1% can be used, which provides a very effective hemostatic effect. So it acts by precipitating proteins. Okay, it also precipitates thrombin, so that form the clot at the site of the bleeding. So it controls the capillary oozing. So whenever there is a bleeding from the capillary, you can directly apply this tannic acid over the site of the bleeding. Next, we have the adrenaline. I think you are very familiar with the word adrenaline. What is adrenaline? Anyone? Adrenaline. Have you heard this drug's name? Adrenaline. No? It is a sympathomimetic agent, no, that increase the blood pressure. So it acts by the various mechanism. It is a non-specific that act in the various receptor, alpha 1, alpha 2, beta 1, beta 2, and beta 3. All receptors it act. But in this condition, it act by acting on alpha receptor. So it has an alpha action in the blood vessels. So by acting on the alpha receptor, it causes vasoconstriction. Okay, thereby decreasing the bleeding, thereby arresting bleeding. So this drugs, this adrenaline, we can soak in the cotton pad. Okay, 0.1% adrenaline you can put in the cotton pad and applied on the site of the bleeding, that control capillary oozing. That this is also very commonly used local agents. Okay, local hemostatic agents. So you can apply at the site of the tooth extraction also. In the site of tooth extraction, there is a capillary oozing and from the bleeding from the nose. So whenever in this condition, you can put 0.1% adrenaline in the cotton pad and you can put at the site of bleeding. So that stop the bleeding by its vasoconstricting action by acting on the alpha receptor, okay, in the blood vessels. It should not be given in patient having hypertension, congestive heart failure, arrhythmia, ischemic heart disease, and uncontrolled hypothyroidism. So if you give in this patient, then condition will worsen. Okay, so always you have to ask the history while giving adrenaline, either the patient having any cardiovascular disease or not, or having any thyroid problem. Okay. Next we have thrombin. So this thrombin, it is available in the dried powder form, that is extracted from the bovine or human plasma. Okay, that is extracted from either from the human plasma or from the other cattle like buffalo, cow. Okay, So it is available in the dried powder form. So you can directly apply at the site of the bleeding. Okay, at the site of capillary oozing. It's control bleeding, but it should not be injected intravenously or subcutaneously. Okay, because it produces severe hypersensitivity reaction. So always you should use by the topical route only. Next we have the fibrin glue. This fibrin glue is available in the spray. It contains the factors like fibrinogen, factor 8, thrombin and other clotting factor. So it is a somehow effective local hemostatic agents because it contains the various clotting factor. So this can be used during the surgical procedure. Okay. So whenever the surgery is going on, okay, during the intraoperative period also, whenever there is a increased risk of the bleeding, so you can directly spray this fibrin glue during the surgical procedure. Okay, at the site of the bleeding. Next, we have the gelatin. This is a protein which is used as the hemostatic in surgical procedure. So it is absorbable hemostatic, which is available as a sponge or the film. Okay, it is available in the film or the sponge that you can directly apply at the site of the bleeding. So no need to take out after bleeding. It will self-absorb over there. But the main problem is that sometimes it may produce granuloma or fibrosis. Okay, due to the infection of this film or the sponge. So this is the main drawback of this gelatin. Next is the calcium alginate. So it is extracted from the seaweeds. It is also absorbable, which promote wound healing. Okay. Besides clotting, it also promote wound healing at the site of rupture of the endothelium. Next, we have the oxidized cellulose. So this can be used topically. Okay, at the site of the bleeding, used to control bleeding from the capillaries and small arterioles where the ligation is not possible. Whenever we cannot suture the wound, okay, in that site you can apply this oxidized cellulose. You should apply in dry form. Okay, when you apply in the dry form, it swells up and helps in the formation of clot. This is also absorbable hemostatic agent. Next, we have the hemocoagulase. So this is also known as the viper venom, okay, because it is extracted from the venom of the viper. This venom, this viper species is the Bothrops atrox. Okay, this is a type of the viper. So from this viper, the venom is extracted. That helps in the clotting of blood. Okay, it is a powerful hemostatic agent which convert soluble fibrinogen into insoluble fibrin. Okay, like it act like thrombin. Okay, that convert that soluble fibrinogen into fibrin. That helps in the formation of clot and also shortens the bleeding and clotting time, which reduce blood loss at the site of injury. It is available in the different form: topical, intramuscular, intravenous, and sometimes you can use by the subcutaneous administration. So this can be used by topical as well as systemic route also. This is also known as the viper venom, okay, hemocoagulase. So this finished our coagulants. Now we start with anticoagulants agents. So any doubt in the coagulants? In systemic and topical are the local hemostatic agents. So anticoagulants, it is just opposite of coagulants, okay, the drugs which reduce the coagulability of the blood. So whenever there is an increased risk of formation of thrombosis, embolism, or increased risk of the clotting, in that condition we have to give anticoagulant agents, okay, in thromboembolic disorder. But in the normal condition, our body has natural anticoagulants that I already discussed yesterday. Okay, do you remember what are the natural anticoagulant mechanism? Anybody?
Heparin.
Prothrombin.
Natural anticoagulants, not coagulants.
Heparin, cycline, antithrombin, heparin sulfate.
Yeah, antithrombin 3. You should say antithrombin 3. And other?
13C.
Yes. Prostacyclin also act as a natural anticoagulants. Okay. Heparin sulfate. And we have these drugs, these compounds which helps to prevent the formation of the clot in the flowing blood, in the blood vessels. Okay. But whenever there is an increased risk of the thromboembolic condition, so whenever there is a decrease in the clotting factor, increase in the clotting factor, whenever there is a easily formed thrombus and embolism in the blood vessels, okay, that may lead to the various cardiovascular condition. Okay, that may lead to the myocardial infarction, angina pectoris, okay, thromboembolic condition, pulmonary embolism. So in that condition, we have to give exogenous drug. Okay, that our natural anticoagulant is not sufficient for that condition. Okay, that is a type of pathological condition. So we have to use anticoagulants agents. So these anticoagulants are classified into various headings that used in vitro. Do you know what is in vitro and in vivo? What is in vitro?
Outside the natural environment.
Yeah, outside the body. Okay, outside the body, or that can be used in the lab. Okay, so anticoagulants that can be used outside the body or in the lab. These are heparin, sodium citrate, sodium oxalate, and sodium editate. So these agents can be used outside the body. So whenever we draw the blood from our body, we have to give some anticoagulant agents, okay, to prevent it from clotting, to do some diagnostic test, okay, screening test. So for that, we have to add some anticoagulant agents. So in that condition, we can use heparin, sodium citrate, sodium oxalate, and sodium editate. Okay, so this is sodium citrate used in the blood bank to store blood. Okay, in the blood bank, we have to make the blood in the fluid form only. So we have to prevent the blood from clotting. So in that condition, we have to use sodium citrate in that withdrawn blood. Okay, so these agents can be used in lab or outside the body, and some coagulants that can be used inside body, in the living body. Okay, that is in vivo. So these are classified in further different headings, either used parentally or that can be used orally. Okay, parental anticoagulants and oral anticoagulants, basically two types. Okay, in parental anticoagulants, again we can classify it into indirect thrombin inhibitor and direct thrombin inhibitor. That is, it indirectly inhibits the thrombin. In that we have heparin, that is unfractionated heparin, that is a long chain heparin, low molecular weight heparin, that is a fractionated heparin. In low molecular weight heparin, we have the enoxaparin, deltaparin, tinazaparin, and rivaparin. Likewise, we have synthetic heparin, fondaparinux. The name is somehow difficult. Okay. Direct thrombin inhibitors, we have lepirudin, bivaliverdin, and orgotavan. So these are the directly acting on the thrombin. Next, we have oral anticoagulants that can be used by the oral route. Coumarin derivatives, we have warfarin, dicumarol, and the acinocumarol. Indonadione derivatives, we have the phenylnedione, direct thrombin inhibitors, dabigatran. Okay, you should learn, you should study these drugs. These are very difficult to remember, so you have to go repeatedly to remember. So we started one by one. Okay, we'll start with the heparin. Why this name heparin is given? Any idea? What is hepatic?
Liver related.
Okay, it is because it is mostly concentrated in the liver. It is highly extracted from the liver cells. Okay, that's why it is named as the heparin. So around in 1960, one of the medical student that names MacLeon, okay, he discovered that one potent anticoagulant is present in the liver. Okay, he discovered these things. And later in around 1937, another scientist, he named the drugs, these agents, as a heparin because it is highly extracted from the liver. So he named these agents as heparin. Okay, this is a highly concentrated in the liver, so you can extract it from the liver. It is a non-uniform mixture of the straight chain sulfated mucopolysaccharide. So it is a long chain of the polysaccharide having the high molecular weight around 10,000 to 40,000. See, it has a high molecular weight, so it is a heavy compound. Strongest organic acid present in the body. So it is an organic acid. This heparin is present in almost many cells of our body, cells and the tissues that contains mast cells. So this heparin is present in the mast cells along with the histamine. Okay, wherever the organs or the tissue that contains high amount of the mast cells that contains heparin. So our liver has a that abundant mast cells. So it is highly extracted from the liver. That's why its name is given as heparin. Other sources are lungs and intestine. Okay, besides liver, we can extract from the lungs and the intestine. Commercially, it is produced from the ox lungs and pig intestine. So synthetic preparation, they are obtained from the ox lungs and the pig intestine. But naturally, this heparin is extracted from the liver. Okay, mostly present in the liver. So now let's see what is the mechanism of action of heparin. So all of you know what is antithrombin 3. Okay, it is a natural anticoagulant. So without heparin also it shows anticoagulant effect. Okay, in the physiological limit only. Okay, it inactivates the activated clotting factor like factor 2, factor 10, factor 11, factor 12 and factor 13, thereby inhibiting the coagulation cascade. Okay, it is done in the natural phenomena. But when you add heparin, it will accelerate the action of the antithrombin 3 by 1000-fold. You can see here, okay, 1000-folds the action of this antithrombin is enhanced. Okay, so thereby there is a active inhibition of this clotting factor. This activated clotting factor are inhibited 1000 times. Okay, when adding this heparin to antithrombin 3. Otherwise, normally also this antithrombin 3 that inhibit the activated clotting factor. But when we are adding heparin, it inactivate by 10,000 times. Okay, so it is a very potent anticoagulant agent. You can see here in this figure. Okay, this is the antithrombin 3. This is a unfractionated heparin that contains the long polysaccharide chain. You can see here. Okay, this is a factor 2 and factor 10. So these heparin drugs that predominantly inhibit the activated factor 10 and factor 2. Okay, it is a more specific to this two activated factor. Okay, mostly activated factor 2 and 10. So these activated factors require different length of the heparin to be inactivated. Okay, this is very important. You should know. These are the activated factor. Okay, 10 and 2. These activated factors require different length of the heparin to be inactivated. That you can see here. These are the long heparin chain. Okay, these are the unfractionated heparin, and this is the low molecular weight heparin or the fractionated heparin. Okay, you can see here this unfractionated heparin that covers this antithrombin 3 as well as this activated clotting factor 2. So to inactivate this activated clotting factor 2, it requires the coverage of all these factor as well as antithrombin 3. Clear? Only then this factor is inactivated. Otherwise, this factor 2 is not inactivated if it is not covered by this heparin molecule. So when this heparin comes and bind with the antithrombin 3, it forms it causes a conformational change in its own molecule. That is antithrombin 3 that undergo the conformational change here. See the structure of antithrombin 3 here initially, and after binding with the heparin molecule, see the structure here. Okay, this is the conformational change produced after binding to the heparin. So when the conformational change is there, it is more accessible to this activated factor. So it is easily bind with the activated factor 2, and this factor 2 become inactivated. Okay, so that it will not bind its respective receptor. So it does not show any coagulation activity. It does not enhance, it does not initiate the cascade of coagulation reaction. So this complex become inactivate. Okay, this antithrombin 3 and this activated factor 2 become inactive. So when this antithrombin 3 makes this clotting factor inactive, then again it will release from the heparin side. This heparin is released from this complex. Okay, antithrombin 3 activated factor 2, and again it will go and bind to the new antithrombin 3. Again the process is continued like this. Okay, but you can see here this factor 10, activated factor 10, that does not require the full coverage of this factor as well as antithrombin 3. Even if it covers the antithrombin 3 only, this is sufficient for the factor 10 to be inactivated. See here, if it covers, it is okay. That is inhibited by this complex. But in some condition, if it is not covered by heparin also, this factor 10 is inactivated here. Okay, but for the inactivation of the factor 2, always this heparin molecule should cover this antithrombin 3 as well as this activated factor 2. But for the inactivation of factor 10, only this coverage of the 83 and 83 is sufficient. Okay, to inactivate factor 10. So this is the difference between low molecular weight heparin and unfractionated heparin. Okay, that it inhibits both activated factor 2 and activated factor 10, but this low molecular weight heparin that inactivate factor 10A only, not 2A. The reason you know. Again, this will release from the complex and that will again bind to the new antithrombin 3. So this is how this heparin helps indirectly in the clotting cascade, okay, in anticoagulation process, not directly. Okay, by binding with the antithrombin 3 and inactivate the thrombin. So it is the indirect thrombin inhibitor. That's why the name is given indirect thrombin inhibitor, because it only enhances the activity of antithrombin 3 by 1000-fold. Any doubt in this mechanism? This is very important. Why this activated factor 2 is not inactivated by the low molecular weight heparin? That is one of the viva type of question. Okay. If you give in very higher dose, this heparin also inhibit the platelet aggregation. Okay, in the higher dose there may be increased risk of bleeding. You can see here in the clear diagram. So this is the normal condition without adding heparin. So this is the activated clotting factor. This is the antithrombin 3. So this is the normal physiological process. So inactivation done in minimum. Okay. So when after adding this heparin molecule or the heparin, so you see here the coverage of all this activated factor 2 and this antithrombin 3. But for the inactivation of this factor 10A, only the coverage of the antithrombin 3 is sufficient. Okay, there is no requirement of covering all this clotting factor as well as antithrombin 3. If it covers, also it inactivate factor 10, but in some condition, if it is not covering the factor 10A also, it inactivate this factor 10A. Okay. This is the very basic concept in heparin. Now see the pharmacokinetics of heparin. So this heparin is a very large molecule having the having the high molecular weight. So it cannot be given by the oral route. So there is no oral absorption of these drugs, okay, because it is also highly ionized molecules. So if the drug is highly ionized, we cannot give by the oral route because the ionized drugs cannot be absorbed. So always you have to give by the parenteral route, okay, either intravenously, intramuscularly, or subcutaneously. So when you give by the intravenous route, it acts very rapidly. Okay, within a second, it shows its action. So in case of emergency, you prefer this IV route. But after subcutaneous injection, it shows its effect after 60 minutes. So we can see the effect after 1 hour after subcutaneous injection. So the subcutaneous injection can be given in case of prophylaxis or whenever there is no emergency condition. Okay. It is a highly protein bound drug, so it does not cross the blood-brain barrier or placental barrier. So it is safe during pregnancy. Okay, this heparin we can use in thromboembolic condition in pregnant women also, because it is a highly ionized drugs, high molecular weight drugs, and high protein bound drugs. It does not cross the blood-brain barrier as well as placental barrier. So it does not have any CNS effect also, and it does not have any teratogenic effect. So you can give safely to the pregnant lady. Okay. It is metabolized in the liver by heparinase enzymes, and the fragment or the metabolites are excreted in the urine. So whenever there is any liver disease patient or the kidney disease patient, you have to decrease the dose of the dose of the drugs, because it is metabolized in the liver. Whenever there is any liver condition, liver cirrhosis, and the drugs is not metabolized, so there may be chance of accumulation of the drug, thereby increasing the risk of complication. Okay, in that condition, either you have to decrease the dose or you can give to another drugs, okay, that is not metabolized in the liver. So let's see the unitage and administration. How the heparin is given in what unit. Okay, this measured in unit, not in the milligram, gram. Okay, these drugs. This heparin is always given in the unit. That unit, 1 unit means amount of the heparin that will prevent 1 ml of citrated C plasma from clotting for 1 hour. Okay, if you give 1 unit of heparin, it will inhibit the clotting of 1 ml of plasma. Okay, after adding this citrated some citrate, okay, in that plasma, after the addition of 0.2 ml of 1% calcium chloride. So this 1 unit of the heparin that will prevent 1 ml of the plasma from clotting for 1 hour. So this is known as 1 unit. Always you have to give in the unit. It is available in the unit. Okay. Conventionally given intravenous route for treatment. Okay, for the treatment you follow intravenous route, but for the prophylaxis you can give subcutaneous route. Initially bolus dose of 5,000 to 10,000 unit. In the children you can decrease the dose, or you can calculate by the unit per kg dose. Okay, how many unit is required for the certain weight of the children, followed by the continuous infusion of 750 to 1000 unit per hour. Initially you have to give the bolus dose, and after then you have to give the slow continuous infusion, right, decreasing the dose. During the therapy, the APTT monitoring is necessary. Okay, this is a very important point. While you are giving this heparin, always you have to monitor the APTT. Do you know what is APTT? Any idea? I think you have already studied in physiology, pathology. What is APTT?
Partial thromboplastin time.
This is the activated partial thromboplastin time. What is this? This is a full form. What is activated partial thromboplastin time?
It is used to monitor the intrinsic factor defect.
Which deficiency, which defect, either in intrinsic factor or extrinsic factor?
Intrinsic and common factor.
Yeah, in common factor is both increased. Okay. When there is a when this APTT is increased, level of APTT is increased, and it shows that there is a defect in the intrinsic factor. Okay. So this is the screening. It is a type of the screening test. Mostly to know the clotting time. Okay. So if you withdraw the blood from your body and you keep in the glass bottle, and after adding some reagents, you can see the clotting time of that blood. Okay, what is the normal clotting time of the blood? Okay, after adding some reagents, normally the APTT is around around 20 to 40 second, no, 30 to 40 second normal APTT. So when you give the anticoagulant agents, the APTT is normally increased because we are adding anticoagulants. No, we are giving anticoagulants in that patient. So the clotting time is prolonged, okay, by giving the anticoagulant. So this clotting time should be observed while you are giving heparin, okay, to prevent the complication of the bleeding. When you give the excess amount of the heparin, there may be chance of excessive bleeding in that patient. So always you have to monitor the APTT level while giving heparin therapy. That is a very important thing. Okay, you should know. So this APTT levels should be in the range of 1.5 to 2 to 5 times than that of control. If it is a normal range 30 to 40, then you can maintain this level till 60 to 80 second or 50 to 80 second, not more than that. Okay, if this APTT level is increased more than 2 to 5 times or more than 80 seconds, then there may be the increased risk of bleeding due to heparin. Okay, so always you are giving heparin, and you have to always monitor the level of APTT. So that is very important things. Okay. Subcutaneous is given for prophylaxis or condition where IV cannot be given. Okay, in case of prophylaxis where we don't need immediate action or immediate effect, in that condition you can prefer subcutaneous route also. Okay, or in some patient where we cannot give intravenously. But IM route is not preferred because there is a high risk of the hematoma formation. Okay, so never give by the IV route, IM route, sorry. Now, what are the uses of heparin? So heparin is commonly used in various thromboembolic condition. Okay, when there is a chance of formation of the thrombus or embolus in our blood vessels, in that condition we can use the heparin, like deep vein thrombosis, pulmonary embolism, unstable angina. Okay, in case of angina we have to give heparin to prevent the myocardial infarction, or for the prophylaxis of myocardial infarction also. Okay, or after the treatment of myocardial infarction, we can continue with the heparin, prevent the reinfarction. In various cerebrovascular diseases, okay, rheumatic heart disease with the atrial fibrillation, during or after coronary angioplasty. Okay, do you know what is angioplasty? What is angioplasty? No idea?
To restore the blood flow through an artery.
Yeah, whenever there is in some condition there is a formation of clot, okay, in the blood vessels, so that prevent the blood flow to the heart. Okay, in that condition we put some catheter, okay, balloon catheter inside the blood vessels where there is a formation of the clot. Okay, so that balloon or catheter balloon, that will widens the blood vessels. Okay, that prevents the formation of the clot at the site of the clotting. So we can directly insert the catheter balloon at the site of the clot formation, okay, at the site of block area, so that it will widens the capillaries and there is a easy flow of the blood to the heart. Okay, this procedure is known as angioplasty. So whenever there is a blockade to the artery, in the artery, okay, in the coronary artery. So in that condition, we can give heparin during the coronary angioplasty and also after angioplasty. And cardiopulmonary bypass surgery, okay, after the cardiopulmonary bypass surgery also, we have to give heparin for the prophylactic therapy to maintain patency of the shunt and cannula during dialysis. Okay, during the dialysis, to prevent any blocking in the cannula, we can give heparin to maintain the patency of the tube. Now let's see the adverse effect of heparin. Bleeding due to the overdose. This is the very or most common complication of the heparin. So to prevent this, always you have to monitor the APTT level. Okay, it should be in the range of 1.5 to 2.5 only. If it increases more than 2.5 times, then there is an increased risk of bleeding. Okay, life-threatening hemorrhage may be seen due to the overdose of heparin. So this overdose can be rapidly controlled by giving protamine. Okay, it is the antidote of the heparin overdose. Heparin protamine sulfate, that is a heparin antagonist. It is a strongly basic protein. Okay, this heparin is a acid and this protamine is a basic. So there is neutralization, formation acid base, there is formation of the salt. Okay, so there is a rapidly neutralize the anticoagulant effect of heparin. So whenever there is an increased level of the APTT due to the overdose, you directly inject protamine sulfate. Okay, to prevent the life-threatening hemorrhage in that patient. There is a transient and reversible alopecia, that is falling of the ear fall. Okay, that alopecia. The exact mechanism of this is not known yet. Okay, so in some unknown mechanism, it causes fall in the hair. The patient who are taking heparin, there is a loss of hair, baldness. The next is a heparin-induced thrombocytopenia. This is also very dangerous complication of the heparin. It is, although it is rare, but it is very dangerous. Okay, mostly seen in the unfractionated heparin, large molecular weight heparin, then with the low molecular weight heparin. It occurs due to the aggregation of the platelet. So this aggregation is due to the formation of the antibodies. So you can see here in this figure, okay, this is a platelet, this is a heparin. So it acts as an antigenic factor. So this antigenic, there is an induction of the antibody production. Okay, so this heparin and platelet complex that induce the formation of the antibody. So this antibody will cause aggregation of the platelet in the blood vessels. So after aggregation, there is a damage of this platelet. So thereby decreasing the number of the platelet in the blood. That leads to thrombocytopenia. Okay, due to the formation of the antibody against the heparin platelet complex. This is known as heparin-induced thrombocytopenia. Clear? This is a very important complication, very dangerous complication of heparin. So if the condition is seen, then immediately you have to stop the drug, both low molecular weight heparin as well as unfractionated heparin. Next, we have osteoporosis. Okay, these drugs also produce osteoporosis on long-term use, basically with the high doses. Okay, because these drugs will accelerate the osteoclastic activity and inhibiting the osteoblastic process, thereby leading to osteoporosis. In susceptible individuals, it also produces hypersensitivity reaction like urticaria, rigors fever, and anaphylaxis. So if this condition is seen, immediately you have to stop the drug. Okay. So these are the very commonly occurring adverse drug reaction of heparin. So you can see here in the figure so that you can remember easily. These are the side bleeding, hypersensitivity reaction, osteoporosis, heparin-induced thrombocytopenia, and raised liver enzymes. Okay, alopecia. Okay, fall of the hair fall. What are the contraindication of heparin? So you should not give this drug in bleeding disorder or history of the heparin-induced thrombocytopenia. If the patient has already the history of this thrombocytopenia, never use this drug. Case of hemophilia due to the deficiency of factor 8 and factor 9, that is hemophilia N and hemophilia B. So you should not give this drug in case of hemophilia, severe hypertensive patient, intracranial hemorrhage, bacterial endocarditis. Also, you should not give this drug. Active tuberculosis. Okay, there may be chance of flaring of the disease due to the decrease in the platelet counts. Peptic ulcer patient, because it is a strongly acidic drugs, that may aggravate the peptic ulcer condition. Okay, in case of threatened abortion also, you should not use the drugs. Cirrhosis and renal failure, because this drugs is metabolized in the liver and excreted in the urine. So the patients who are having liver disease or the any kidney disease condition, you should avoid this drug. Otherwise, there may be severe complication due to the toxicity, due to the accumulation of the drug. Next, you have the low molecular weight heparin. Okay, this is the fractionated heparin. The previous one unfractionated heparin is the long chain polysaccharide molecule having the high molecular weight, but this low molecular weight heparin is a fractionated heparin having the low molecular weight, that is only 2000 to 9000. Okay, it has a shorter polymer length and inhibit activated factor 10 predominantly. Okay, because it has a short polymer, it will cover only the antithrombin 3 only. Okay, there is no coverage of the factor 10 or the other factor 2. So factor 10A does not require the coverage of it by the heparin, so it is inactivated. But other that factor 2 requires the full coverage by the heparin molecule, so it is not inactivated. Okay, so it mostly or predominantly inactivate the factor 10, and it has a very lesser effect on thrombin platelet function and on coagulation. It has a high effect on factor 10. Thrombocytopenia is less frequent and chance of the hemorrhage is also less because it has a less effect on platelet function. So it has a less chance of thrombocytopenia and less chance of hemorrhage. So complication is less than that of the unfractionated heparin. The mechanism of action, this I have already discussed in heparin. This is the antithrombin 3. These drugs also enhance the activity of this antithrombin. So it is also indirectly acting thrombin inhibitor. Okay, this is a low molecular weight heparin. See the length of the heparin molecule. It is not so big, so large. Okay, so it covers only this antithrombin 3. Even it covers this antithrombin 3 only, it inactivates this factor 10A. So there is no requirement of coverage of this activated factor 10 to be inactivated. Okay, so there is a conformational change occurred in this antithrombin 3, and this factor 10A will go and bind to the antithrombin 3 and form a complex, and thereby inactivating this factor 10. So the cascade of reaction will be inhibited, and this heparin, after forming the complex, it will release from this site and again it will bind to the new antithrombin 3 to inactivate other factor. Okay, this is how these drugs predominantly act in the activated factor 10. So what are the advantages of this low molecular weight heparin over high molecular or unfractionated heparin? It can be given subcutaneous, better bioavailability. Okay, if you give by the subcutaneous route also, it has a 90% bioavailability, longer elimination half-life, and are eliminated by first order kinetics. Okay, so because of this longer half-life, you can give this drug once daily. Okay, there is no frequent dosing of this drug, no requirement. So once daily dosing is sufficient because of the long half-life. Do not prolong APTT and hold blood clotting time. So there is no requirement of monitoring of the dose, unlike heparin. Okay. Response is predictable and monitoring is not required in this condition. Dose is given in milligram, not in unit. Okay, this low molecular weight heparin can be given in milligram. The dose can be easily adjusted on the body weight basis. So these are some advantages of the low molecular weight heparin over heparin. Indication is almost similar to that of heparin. Prophylaxis of deep vein thrombosis and pulmonary embolism in high-risk patient undergoing surgery. Okay, those patients having deep vein thrombosis and who are undergoing this surgery, you can give as a prophylactic drugs. Stroke or other immobilized patient. Treatment of established deep vein thrombosis. Unstable angina also to maintain patency of the cannula and shunt in dialysis patient. Okay, to prevent clotting inside the cannula. So these are some difference between heparin and low molecular weight heparin. Most of the things we have already discussed. It inactivates thrombin and factor 10 because it has a long molecular weight that covers the factor as well as antithrombin 3. Okay, so that it inhibits both thrombin and factor 10. But this low molecular weight heparin only inactivate factor 10 only, not 2, because this factor 2 require the full coverage of factor also. Okay, factors as well as antithrombin 3. It has a short half-life, frequent dosing by the subcutaneous route. So this heparin, but this low molecular weight, it has a long elimination half-life. So once daily dosing is sufficient in this condition, more side effect like bleeding, and it has a less side effect. Okay, low molecular weight heparin requires lab monitoring. APTT levels should be monitored repeatedly during heparin therapy, but it is not required in case of low molecular weight heparin therapy. Risks of the heparin-induced thrombocytopenia is high because due to the induction of the antibodies formation, and that will destroy the platelets that lead to thrombocytopenia. It has a less risk with low molecular weight heparin. This is cheaper. Okay, heparin is cheaper while this low molecular weight heparin is expensive. This is one of the drawback of low molecular weight heparin. Antidote is protamine sulfate. Okay, in case of overdose of the heparin, we can immediately inject protamine sulfate intravenously. But in case of overdose of this low molecular weight heparin, there is no antidote. Okay, this is also another drawback of low molecular weight heparin. But these all other, except these two, all other are the advantage of low molecular weight heparin over this unfractionated heparin. Clear? So this is all about our heparin, okay, unfractionated heparin and low molecular weight heparin. Any doubt till here? No? Time is also only 5 minutes we have, so I think we should stop here. Okay, the remaining portion I will continue on Sunday. Any doubt in heparin? What is the mechanism of action? What are the complications? And what are the therapeutic uses of heparin? And how it differs from low molecular weight heparin?